is more involved on our state level.
Yeah.
And who is an epidemiologist.
So it could be actually more than that, because usually it's like.
Just because he thinks differently than I think.
Yeah,
You know?
well, when you get back, let's set that up, maybe a Zoom meeting.
And I don't know, well, I have my own mentoring. Right. But jump over here, so like, you just have more time, you know, and we try to do a good job with that with like. And worse, students and doctors, you know, and like, and these students and.
Just putting the time to do it.
Yeah.
Yeah. And for our.
It's my pleasure today to. Okay, and forgive me for reading a little bit, because I want to make sure I get all of the distinguished credentials here. My pleasure to introduce Dr. Lisa Sanderson Cox, Professor of Population Health at the University of Kansas School of Medicine, our neighbors to the east. She's also Associate Director of the Frontiers Clinical and Translational Sciences Institute, University of Kansas, a member of Cancer Prevention and Control. Thank you for our host today, the University of Kansas. She is also adjunct professor of clinical psychology at the University of Kansas and an NIH-funded researcher from NCI and NIDA. She has been a real leader in advancing and promoting tobacco cessation and treatment and reducing tobacco-related morbidity and mortality in populations like African American and Latino smokers. Is a great and amazing record of community collaboration, working with several qualified health centers and others. I don't think I'm even scratching the surface of all of her amazing list of research, but I really look forward to hearing more about it today. Thank you.
Thank you. Okay, so before I dig in, can I get a sense of, in this room, what departments are we covering? Like, what areas are we covering besides we're all coming together as cancer prevention and control?
Psychiatry.
You've got psychiatry, general internal medicine,
Community behavioral health.
community behavioral health,
Environmental.
okay.
Population health on the clinical research side.
Awesome, okay,
Hospital medicine.
nice. Okay, and how many people here are trainees? Okay, and how many people here are running clinical trials? Okay, I'm just getting sort of a little bit of sense of things, but this is really fun, and it's really fun to be here. This is my first visit, which I'm excited to be here. And yes, we're neighbors next door. And of course, unlike being neighbors next door, if you live in Washington, D.C. and you touch multiple states, we're neighbors next door where we could spend the entire day driving and enjoying the countryside and finally reaching here. So thank you. I'm really, really glad to be here. I'm going to make sure that I am, there we go. Okay, so what I'm going to eventually dig into is looking at characteristics of tobacco use and related disparities, specifically looking at differences between Black adults and typically non-Hispanic white adults. I'm going to go over some of that so we can look at sort of a rationale of why would we ever look at a specific population. And then I'm going to review some of our evidence-based treatment findings. I'm just going to give a sprinkling of some more clinical findings and then discuss some factors that we might want to consider if we're looking at research and treatment to support Black adults in becoming smoke-free. So some of the talk is more clinically focused, but the questions I hope that come into your mind are how do some of the things that I'm sharing with you today impact, like how you might think about assessment, how you might think about protocols, how you might think about research design and so forth, so that we can have discussions on whatever direction that you would prefer. Okay, I will mention, I'm not going to be like focusing on the C3I, but I will say that one of the things that the University of Kansas has in common with the University of Colorado is that we were one of the first groups of the NCI Cancer Center Cessation Initiative that started in 2017 that Dr. Levinson led here at the University of Colorado and my colleague Kim Richter led at the University of Kansas, really focusing in on how critically important it is to help people quit smoking, not just the general population, but even individuals who are coming in, getting a cancer diagnosis. It's really essential that we're addressing tobacco treatment for everyone. And so, for instance, our cancer center now, for every new patient, is sending them information, even in their starter pack, like of what it's going to be like to go through cancer treatment, emphasizing the importance of quitting smoking. This is just part of page one of the forms that they receive. But it is really important to be addressing tobacco use as soon as you possibly can. Even at the point of a cancer diagnosis, this is a really great oncology paper from last year that emphasizes, is it really, should that be the focus? We're dealing with people who are really stressed out with a new cancer diagnosis. They're dealing with a million things. Should we really be adding tobacco treatment on top of it? And yes, because we see reduced mortality and we see in their particular analysis, 1.8 years of life added with early post-diagnosis quitting. So supporting quitting right away, it literally adds years of life. And they anticipate that, or they suggest that that's probably a very conservative estimate. That's very conservative from their analytical approach, but this is not my topic today. What I want to spend some time talking to you guys is about the history of research that I've been doing with the team at the University of Kansas, focusing in on addressing health equity by improving treatment for Black adults who use tobacco. So tons of people at my institution and lots of people with interinstitutional collaborations. I will say this is a great example of reaching out to people that you're not currently working with and just asking if they're interested in collaborating. That's something that I was really fortunate in being able to do even at my very earliest phases of my career. And it's such I think, you know, you look around people in this room, these are people who are really passionate about what they want to do or what they're doing. They really care about population health, about cancer prevention control, and they want to help solve problems. So it's the perfect group to reach out to collaborate with. And it sounds like through CoNECTR that you guys have so many really cool projects going on, so many people with different expertise. This is kind of the perfect environment to be doing the same thing, even within your own institution, because there's always room for collaboration and you can answer more interesting problems that way. So I'm not going to focus on just one study. I'm just saying this, you don't have to read all the details on the slide, but this just gives an overview of the clinical trials that I've been able to be involved with Nikki Nolan, Jazz Alawali, and other people at my institution. They've all focused on answering questions about how to better treat Black adults who smoke. And over about 25 years, I've been involved for about 20 years. We've been able to reach and treat over 4,000 Black adults who smoke. All of our trials involve pharmacotherapy, and many of the questions are just trying to identify pharmacotherapy efficacy and benefits with individuals. Now, the work that I do couldn't be done without community engagement. And community engagement really involves relationships and building trust over time. And in a perfect world, being able to figure out ways to continue those relationships and not just be hopping in and out based on NIH funding or that sort of thing. Also, our community that we've really pulled together to help support the work that we do isn't just the healthcare community or the research community, but it's also just general organizations in the community. Can they be involved and help sort of support some of the work that we're doing in terms of even messaging about how important it is to be tobacco free? We're really thankful for our former mayor and longtime Congressman Manuel Cleaver, who's also been a really solid advocate and a voice that people really trust in the Kansas City area, so that's made a big difference. And why do we do all we do? We do all of this because we believe that everybody deserves a tobacco-free life. This is really the theme and emphasis of the 2024 US Surgeon General's report on eliminating tobacco-related disease and death through addressing health disparities. A theme that we still really value. And I wanted to share this particular QR code with you, and these slides will be available for you after the fact. But I put this QR code because the CDC has taken down the link to this report. The Surgeon General's office still had the link to this report a week ago, but who knows? But luckily, the University of California, San Diego has made sure that they are archiving these reports so that they're still available. But this is really fantastic, whether you're talking about intervention, whether you're talking about policy, this particular document has been in the making for over a decade, and it's really fantastic. So one thing I want to do to just take a little step back is provide a little context for why am I interested in doing what I'm doing and why we might want to think about different populations in their own historical context. If you think about Black adults who smoke in the United States, it really is necessary to pause and say, wow, we actually live in a country that was developed emphasizing the importance of slavery and tobacco production for the economy that this country was really built on. And so the history of slavery is central to leading us to where we are right now. The history of tobacco production is really central to the importance of slavery in our country's history. And whether you're talking about any point in time over the course of hundreds of years, even moving into the 20th century, even moving into civil rights, and changes in the law, and changes in redlining, and changes in access, and improvements in health equity, we still have the long-term effects that impact this population and impact many areas of their general lives, including their tobacco use. And when you look at tobacco industry, the tobacco industry has a history of marketing and targeting particularly disadvantaged populations. So when you think about higher rates of tobacco use, whether you're talking about socioeconomic disadvantage, whether you're talking about LGBTQ populations, whether you're talking about Black populations, the tobacco industry targets and has a massive impact on tobacco use advertising and exposure and so forth. So it is important to think about not only like individual tobacco use behavior or familial impact or social impact or community impact, policy impact. There's so many different levels that influence one individual's exposure to tobacco, their uptake of tobacco use, their access to care, their treatment outcomes, and so forth. So that bigger picture is important when we're thinking about, oh, what is it like to have this one person come into our study, right? So some differences in tobacco use. Since the 1964 Surgeon General's report, obviously we have tobacco use decreasing in the United States over time, so that's fantastic. This particular slide shows different color lines or different racial ethnic populations, and so we see differences in tobacco use across different groups. It gives us a very, very broad picture, but not very much detail. And even if you're looking at like, okay, let's take recent data and look at differences in tobacco use prevalence across racial and ethnic groups, that's still a real, not very specific picture. Because, for instance, even if we look at American Indian and Alaska Native tobacco use prevalence, if you look at different communities, if you look at different tribes, if you look at rural and urban, you see so many differences. And so even prevalence data only gives us a tiny bit of the picture. Now you can break this down even further and you can say, okay, well, let's look at prevalence by different factors. And so for instance, if you look at tobacco use prevalence by education level, and education level is also highly correlated with socioeconomic level. You'll see that if you look at the highest level of education in the lower right-hand corner, you see very little difference in tobacco use prevalence. But if you look in the upper left-hand corner and you look at individuals with less than high school education, you see a much higher prevalence overall. And you see greater differences between racial and ethnic groups, but you actually notice that if you look at Black and white individuals, they're still very relatively similar in tobacco use prevalence. But again, differences on education and also prevalence just means, are you using tobacco? How much tobacco are you using is a different question. And so if you look again at something like cigarettes per day, you get also very different pictures if you look across education levels. You see fewer cigarettes per day with higher education. But you notice in the upper left-hand corner, there's really stark difference between cigarettes per day between white and Black adults who use tobacco, and that Black adults smoke significantly fewer cigarettes per day. So this is just a little bit of the example of how you actually can see very big differences in tobacco use prevalence, cigarettes per day, once you start looking a little bit more granularly, which could support the argument that there is value sometimes in looking at a smaller subset of the population when you're trying to figure out how best to treat, to overcome, or to improve health equity. Same thing when you look at menthol use. Menthol use really varies. And this is partly related to tobacco industry marketing and targeting. So if you're going to summarize, again, the Black adult population is a very heterogeneous population. You have a lot of differences based in education, income, region of the country, all sorts of things, right? But if you were going to generally summarize, we see that Black adults tend to have similar prevalence in smoking to whites, but are more exposed to tobacco industry targeting, tend to smoke menthol cigarettes, like vastly more so, smoke fewer cigarettes per day, and have slower nicotine metabolism. So if you stop and think about this, so nicotine metabolism, how quickly do people take in the drug and actually metabolize the drug? How long are they going to have nicotine in their system? If you are a slower metabolizer, you could take in drug, it's in your system longer, which would kind of support the concept of you using fewer cigarettes per day. It might make you think, well, what does that mean for dosing if you're dosing nicotine replacement therapy? And there's not a perfect answer to that, but if you need to dose, overdosing nicotine replacement is probably a good idea. But let's not get too far ahead of ourselves. Higher codeine levels per cigarette. So with a given cigarette, it's also more likely that you'll see Black adults get more nicotine out of a given cigarette. So it may be, and this might be related in part to using menthol, which makes inhalation much easier. So you're combining menthol and you're getting more nicotine from a given cigarette. So these are all things that to some degree impact how am I going to treat an individual, and Blacks may look different than some other racial and ethnic populations. Also, within the Black population in general, you'll see more co-use of other tobacco products, including things like cigarillos, little cigars, and blunts, and co-use with marijuana. And so if we're only asking about cigarettes in our assessment or intakes, whether we're talking about research or clinical settings, we might be missing other tobacco use, and that's something that we've learned over time that we need to do a better job and more thorough job of assessing co-use and other product use. And then Black adults try to quit smoking more often. In a given year, they're more likely to make more quit attempts. Unfortunately, a given quit attempt tends to have lower treatment success than non-Hispanic whites. And despite similar tobacco use prevalence and smoking fewer cigarettes per day, we see higher tobacco-related morbidity and mortality and higher cancer incidence and morbidity within Black adults, which doesn't make sense. You just, look at it at the sheer numbers. But when you start thinking about, okay, but wait, what does greater inhalation mean to exposure to carcinogens? Or more importantly, how does access, healthcare, having a medical home play into all of this? Then suddenly that's not that shocking, right? So what can we do to attack this issue on multiple fronts? Now, I do want to point out that when we talk about greater cancer risk, that this is an example related to lung cancer. This is a 2006 study, but it really just displays very clearly. When you look at higher level of cigarette consumption, yes, of course, greater risk with more use when you're thinking about lung cancer specifically. But when you're even talking about low level use, that's actually where you start to see some of the greatest disparities, some of the greatest differences between Blacks and whites at low levels of use. So just like with cardiovascular disease, where we know that even one cigarette per day vastly increases health risks related to tobacco use, when we're talking about cigarette smoking and lung cancer risk, even low level use actually significantly increases lung cancer risk, especially for Black adults. So things to keep in mind. Now, on the issue of lung cancer, I will say I was really interested in this 2024 article that looks at pack-year smoking history and what current clinical practice guidelines are for recommendations for lung cancer screening. And if you are going to base lung cancer screening recommendations on pack years of tobacco use, and if Black adults tend to smoke fewer cigarettes per day, then you could have someone who is smoking for 20 years, and if they're white and they're smoking a packet, well, whatever their racial ethnic background, if they're smoking a packet a day, then 20 years, 20 pack history, fine. If they're only smoking 10 cigarettes per day or 5 cigarettes per day, are you saying we need to smoke 40 years or 80 years before they would have that really increased lung cancer risk and need lung cancer screening? That's where it really, if you don't stop and think through the math, where it doesn't necessarily add up. And this is a paper that says, wait a second, maybe we need to be thinking just about years of smoking as opposed to pack years of smoking in terms of looking at who really is at increased risk and needs cancer screening. So I thought that was interesting. This is another good reference, but this is more just about how even the lowest level of consumption is important. So high-risk group, but less likely to access treatment, less likely to receive advice to quit smoking, even when they do have contact with medical providers, and less likely to receive pharmacotherapy from providers, even when they are talking about quitting smoking. Now, I think historically there is this sense of like, oh, some groups don't want to use pharmacotherapy. Okay, well, Black adults who smoke want to use pharmacotherapy, and pharmacotherapy is effective, and it needs to be an essential part of treatment in those conversations. And things like education can also be a helpful piece in whether someone is interested in using pharmacotherapy. Okay, so we really would like to put all of our efforts together to improve tobacco treatment outcomes in this group. So what have we been doing with pharmacotherapy? Now, I am not giving you a full review of all pharmacotherapy clinical trials for Black adults. I will say our particular team has done a majority of the pharmacotherapy trials that have focused specifically on Black populations. Now, I'll mention if you look over the decades of clinical trials that have been done for pharmacotherapy treatment, really establishing the importance and benefit of pharmacotherapy treatment in treating tobacco use. The majority of trials don't include light smokers. So that's a problem. More today are, but even for instance, the Eagles study, which was one of the largest clinical trials, multi-site international study looking at all of the currently FDA approved pharmacotherapy options, didn't include light smokers, right? So having more studies on light smokers is something that was recommended by the 2008 clinical practice guidelines, the more recent ATS clinical practice guidelines, like we need more work in that area. But then again, if we see, okay, Black adults have some unique factors and they respond to treatment differently, that's kind of the rationale for doing these focus studies. And if you have a larger clinical trial and you're only enrolling maybe 5% African Americans, even though about 12% of the US population is Black, you just don't have enough data, even if you're compiling data across studies to really speak to that. So that's what we've been doing. Okay, so clinical practice guidelines use pharmacotherapy and counseling. The more recent ATS guidelines, same thing. We know that you're going to double or triple your quit rates if you do that. So across all of our trials, and we've called our studies the Take It at Swope studies because Swope is our federally qualified health center that we do a lot of our work with. And our Quit to Live, which is just another set of studies. We've looked at the different current pharmacotherapies across studies. And I'm just going to give you the spoiler alert is, guess what? Pharmacotherapy is effective in Black smokers. It doubles or triples their quit rates based on or relative to placebo. And so it's something that needs to be used. We still have a lot of unanswered questions, but I thought I would give you just a little smattering, a couple of studies that we've done that might be of interest. Before I do that, let me just give you an example of what our participants look like. Because again, Black adults, heterogeneous population, we are limited in the generalizability of our findings based on who's in our study, but this is just a typical set of a typical group of 500 in one of our studies. The things I would draw your attention to is on the left column, the bottom 2 points. About a quarter live in smoke-free homes, which means the majority do not live in smoke-free homes and are being exposed. And think about just behaviorally how much more challenging it would be to change any behavior with that. And then in this particular study, 2/3 of our sample had no insurance. I'm not talking about did you have private insurance? No, private, federal, nothing. We have a lot of people, I'm sorry, 2/3 have insurance, 1/3 do not have insurance. So, but a third, imagine a third of individuals not having any insurance and how that massively influences access to care. Okay, the other thing I wanted to just point out is in the right-hand column in the middle, 80%, almost 80% smoke within 30 minutes of waking. And this is a group that half of the individuals are light smokers. So light smokers, smoking fewer cigarettes per day does not map very well with how dependent you are on nicotine. Time since first cigarette or time that you smoke from the point of waking up is just a proxy for physical nicotine dependence. It's not a fantastic measure, but it's a good proxy to at least say, oh my gosh, this is a group of largely light smokers, but people who do have some level of nicotine dependence. And then this is just another example right below that the vast majority of individuals in our study smoke menthol. That also means that if we're later looking at individual factors related to quitting, we in our studies actually don't have a very we're not set up to answer menthol questions very effectively because everybody smokes menthol, so we can't really tell you, oh, menthol is or is not associated with quitting. But I think that the data elsewhere, particularly population data, would suggest that banning menthol would really be a positive population health impact in terms of helping people quit. But, okay. Couple examples. Light smokers. We did one trial where we were looking at, this is the first study that we ever said, hey, maybe we should be actually paying attention to light smokers since our population has a lot of light smokers. And in this study, we used nicotine gum and placebo. And we found that dosing is really difficult. And so the concern is more about underdosing than overdosing with nicotine. Even though nicotine can be toxic, it's really difficult to get to too high of a level of nicotine replacement when you're working with people who have smoked at all. And adherence to using nicotine gum was extremely difficult in this particular study. And so it helped us start thinking about what would nicotine replacement dosing look like in the future and how can we really start to build on adherence. The one thing that we did find out in this study, it was a 2x2 design, and health education counseling was twice as effective as motivational interviewing in this particular sample, but these were individuals who were already saying, I want to quit smoking. So if I'm already saying, I want to quit smoking, we don't need to do the reflective motivational interviewing, getting me motivated to quit emphasis. I love motivational interviewing in terms of the spirit of like collaborating with individuals that you're working with. But if you have someone who wants to quit smoking, at least in this group, and what we've seen in our trials is people want concrete recommendations. Use pharmacotherapy, take pharmacotherapy, set a quit date. What do I need to do with my apartment or with my living situation? What are strategies to help manage sleep or nausea? Or what are strategies to help deal with stress? So health education and kind of cognitive behavioral therapy is really beneficial. Another study where we used nicotine replacement looked at non-daily smokers. So I didn't mention this, but as tobacco prevalence goes down overall, we're seeing more light smokers, but also more non-daily users. So people who may just smoke at parties or people who may just smoke on weekends when they have more leisure time or that sort of thing. And so we still know that even low levels of use has high level of risk. So what do we do with those individuals? In this particular study, people had a choice of nicotine replacement in one treatment condition and counseling in both treatment conditions, but one group with no NRT. In this study, there wasn't a significant difference in abstinence at the long-term follow-up, but there was a significant difference in reduction of total days in a month smoked, total cigarettes per day smoked on days where people were using, and a reduction in NNAL, which is a carcinogen related to lung cancer. And so there's definitely opportunity for continued effort on figuring out what to do with light smokers to help reduce harm, but also to help move people towards quitting, and we're just not there yet. Yeah.
Lisa, do you mind a question?
Yes, please jump in.
Since this was voluntary choice on the mode of NRT, what did people choose?
So it was really a mix. I thought it might really lean one way or another. I think we had more people who chose patch and lozenge, like they were given sample packs of all three so they could test them out. And more people ended up going with patch and lozenge. I don't know the numbers off the top of my head. But one of the things that I'm curious about, and this study was not set up to design this because it was a choice of what you wanted to use, but I think an interesting study design would actually be to look at doing an ad lib like lozenge or gum where you can use more or less as you wish versus using a steady state like patch, or even using combo, which you might think, oh, these are only non-daily, so we don't want to, give too much. But those are really different forms of administering a drug. And there may be a real difference in what would be more beneficial or not. of course, the trick would be, maybe there's also individual factors that would make one form better or not. And so, as we were talking, sample size for, if you really wanted to dig into all of that, would be challenging, but these are questions that are out there. I think clinically, it means you could continue working, how's this working? Well, let's try this, well, let's change that, right? And so some of those adaptive responses. One of the things that just came out of non-daily smoker study was just putting together some guidelines for clinicians, because clinicians have no guidelines at this point. And it's just sort of that, you know, there's not a downside of trying nicotine replacement with non-daily smokers, and that you might actually be able to improve moving people closer to quit, or at least reducing harm. So some things with bupropion. We originally had a study back in the day of just including moderate to heavy smokers and finding a benefit of bupropion. So then, both in terms of short-term and long-term treatment outcomes. So then that would be super logical to study the exact same thing, but with light smokers. So we looked at that, the same design, but with just individuals who smoke 1 to 10 cigarettes per day. And we saw a significant treatment effect at end of treatment, but we didn't see a significant benefit at long-term outcome. Until we said, let's look at adherence, because amazingly, you're not going to find a drug effect if people aren't using a drug. So it actually opened my eyes a little bit, like kind of late in life, to the concept of just because you put someone in a condition doesn't mean they're actually getting the treatment of that condition, unless you're actually measuring and figuring out what's happening. So if you actually looked at people who use bupropion, yes, you saw a short-term and long-term benefit of using bupropion. And this really, again, emphasizes this issue of adherence. Are you assessing adherence, and are you counseling on adherence? And whether that's individual counseling, whether that's problem solving about how to remember, whether you're using other devices to help, which we haven't done at this point, but super logical. Are we setting your watch to go off twice a day to take your medications? Am I sending you text messaging, you know, reminders to use your medication, or to help remember why you want to be using medication? Am I helping problem solve any adverse events from using medication so that you're more likely to use those kinds of things? And then right now, we're currently doing a study where we're looking at short-term use, sort of standard treatment of bupropion versus extended treatment for bupropion. From a behavioral scientist perspective, in some ways it almost astonishes me that our drug trials are so short when we're talking about a behavior as pervasive as smoking, that we would really anticipate to see significant behavior change. There's a number of other studies that show the benefit of long-term pharmacotherapy, whether you're talking about bupropion or varenicline, nicotine replacement. We hadn't looked at it in African Americans before, and so this is a study that we're currently looking at. And I think I may accidentally have a repeat slide of that somewhere, which we can skip over later. So varenicline is arguably the leading monotherapy for treating tobacco use at this particular point in time. And our team has 2 different studies that we did with this. One, the top one is a placebo-controlled trial, and the bottom one is a trial saying, what if we enroll white smokers and black smokers who have relatively similar sociodemographics and look at treatment with the same drug? So in the placebo-controlled trial, we found that varenicline was more effective, doubling or tripling increasing odds of abstinence with minimal side effects. So I don't know if you remember, there was a period of time where people were concerned, are there psychiatric side effects for varenicline? And there was black box warning for a period of time. That's been taken away, and we found no significant increase in any psychiatric side effects. The one area that we found a significant difference was in nausea. And so individuals taking even placebo had increased nausea during the course of quitting, but individuals who were using varenicline had greater nausea. But that just meant that our counselors worked with people on, are you taking with food? What type of time of day are you taking? For a handful of people, we did dose reductions and that really did the trick. But we do find that that adherence is also related to treatment outcomes. So if we can improve adherence, we expect to see better treatment outcomes, which then means on that very first day when we're talking to individuals about the rationale for using pharmacotherapy to support their quit attempts, that adherence really needs to be a central part of that. So this is that same placebo-controlled study, and we did not compare light smokers to heavy smokers. What we did is we said, okay, we found the overall benefit, but what if we look just within light smokers and just within moderate to heavy smokers? And whereas with bupropion in 2 separate studies, we seem to have lower quit rates in light smokers. Here with varenicline, we have a really significant benefit of using varenicline with light smokers. And again, in most other varenicline trials, light smokers were not included. So it's nice to start looking at benefits of pharmacotherapy specifically within light smokers. Here, let me go down to this bottom part. In looking at differences between white and black smokers in Nikki Nolan's study, if you look just across the board, you would see, oh, there were higher quit rates in the white group than in the black group. Oh, but okay, so that means whites have an easier time quitting with varenicline, because we set up the whole study to try to make the 2 groups look similar. We had low socioeconomic status for both groups. We had similar male-female, similar cigarettes per day, but actually our black group was just especially low socioeconomic status. So if you actually take individuals who are equally socioeconomically disadvantaged, you actually have almost identical quit rates. So really what Nikki Nolan's study would suggest is sometimes what we seem to interpret as race differences in quitting really may just be more socioeconomic differences in quitting, with the fact that socioeconomic disadvantage is disproportionately seen in Black adults in the United States. So I'm just putting that out there, not to say, oh, well, then I guess we don't need to do, you know, race-specific studies anymore. It's just socioeconomic factors. But what's more important is helping us think through how are we measuring some of the correlates of socioeconomic disadvantage when we're doing our studies so that we can better dig in. And yeah, did you have a question?
Well, related to that, because what I've been thinking about, to this point about like the socioeconomic disadvantage or advantage being really important is, have you looked at like the work environments and employment types of employment among
I don't
participants?
think that we even do a good job of assessing that. I mean, we assess employment status, but we don't dig into what type of employment status. So that's a really interesting. Oh, tell me more.
Because we've been looking into that, because there's some literature that, you know, having effective and supportive like workplace policies at the actual workplace level makes a huge difference in your quit success. And then also there's like the added layer of like, are there smoke-free policies at like the state or municipal level that apply to your workplace?
Yes.
Does your individual industry, for sometimes related to like safety, or for example, in construction, a lot has to do with like the type of construction. Residential construction are much more likely to enforce no smoking or use of tobacco products, because people who are buying the homes will be mad about it.
Right.
So I'm just curious about that, because I think about that a lot, is some of the differences might be related to the industry sectors that people are in. And if, you know, you're trying to quit, but everybody at your job is smoking and so does your manager, and they don't enforce not allowing people to quit the work site, that's going to be good.
I love those questions. And if you're not assessing, like if you're not asking the right questions, then you're not able to analyze to answer some of those questions, which then would give you really great hypothesis generating data to say, oh, here's why we need this type of workplace intervention, or here's why we need this particular type of, community or state policy. I know in federal housing now, that at least in our community, the difference in having federal housing, having smoke-free living requirements made a big, huge difference in terms of people making quit attempts and supporting quit attempts and that sort of thing. But that's a great question. And no, we've not done that. Could do that very easily. And we haven't. And that's the same thing too. In our data, I would say like we are mostly working with housed individuals, but we don't break it down into what type of housing and that sort of thing. And that can have a huge influence on access and, smoking in your environment and that sort of thing. Why am I sharing this slide? I'm sharing this slide to tell you that we took data from those 2 Brennan trials, and we took just Black adults who were in the Brennan conditions across the 2 studies. And so putting those together, we end up with 524 Black adults who used Franklin to try to quit smoking. So that's the largest sample of that group. And we looked at we did a whole set of regression analysis to try to figure out in modeling what are the key individual factors that predict quitting. And 2 of the things that came out, and across our studies, we often will have something come out that's related to socioeconomic disadvantage or advantage. And sometimes it's income. And sometimes it's home ownership, and sometimes it's something like financial strain. In this particular study, when we looked across these, we had home ownership was one predictor, and having insurance or not having insurance is another predictor. So if you say, I'm more advantaged if I have a home, I'm more advantaged if I have insurance, and you put those together, if you look at having neither advantage, and what am I talking about? Abstinence rates, right? So we're talking about people who were given pharmacotherapy. Okay, sorry. Why am I'm mixing up my percentages. So only 11% of our sample actually had both advantages. So only 11% of or 12% of our sample had insurance and owned a home. Okay. 35% of our sample did not have either. Okay. But if you look at quit rates, if you don't have either advantage, we have only 10% who quit. Whereas if you have both advantages, we have over 40% who quit. And we have pretty low quit rates across our studies. And really, again, what we're seeing is if you have a disadvantage, you have like a lot of cards stacked against you in your attempt to try to quit smoking. And some of these just, am I securely housed and have access to medical care makes a big, huge difference. Okay, this just has helped us start thinking more recently about the issue of, Maslow's hierarchy of needs or the health impact pyramid, and really thinking about there are these underlying socioeconomic factors like poverty, education, housing, inequality, that if you are not, if those are the biggest factors that are weighing on your daily life, it's not overly surprising to think that it's difficult to make these changes that are challenging, physically challenging, emotionally challenging, when you're dealing with all of these other things. So what can we do? Because we, as interventionists, I can't give you a house as part of my condition to, see if I can improve quit rates. But what can we do? And it really does add questions, not only from a clinician's perspective, thinking about having navigators in our health system who might be able to connect people to social resources, but it also makes us think differently when we're thinking about policy. One of our MPH students, how are we on time at the moment? Because I know I tend to. What part?
52.
Oh gosh, okay, we're ending. I was just gonna say, one of our MPH students was looking at the fact that not only do we have socioeconomic challenges and different needs, but these individuals who are coming into us, a lot of them are also not connected with a medical home. In this particular study, his sample, more people had insurance, but still are not accessing a regular care provider, and are definitely not up to date on a lot of cancer screening needs. And this would be percentages of those who would be eligible for particular cancer screening needs, having lack of being up to date on those. And so it makes me think of Dr. Cruz and I were talking this morning just about how, we get people in and we try to help them quit smoking, and then we send them out. And we tend to, at the end of the study, here's all these other resources that we can connect you with. But what we're starting to try to do is connect people to other resources within the context of actually providing intervention. And that's something that we're going to try to build into future studies as well, because there's just so much more need than what we're actually doing. So I will not go through everything else at the moment, because I want to leave time for. We talked about the lessons learned. We talked about that there are issues, but there's a lot of different avenues that we could be taking for improving treatment. And so that's kind of where most of our stuff is heading. Why don't I pause here and get into questions while we still have a little bit of time? Because otherwise I will be here for 2 more hours.
Well, I have lots of questions.
You have a lot.
Yeah, you know me.
Ron, you look online in case there's someone who.
Yes, I'm.
Okay, yeah, right.
Where to begin? We've been looking a lot at the socioeconomic influence on failure to quit, and trying to think about it in a public health rather than a clinical context. And quite frankly, I'm sort of stymied. I mean, if we think that what needs to happen is, number one, people need access to pharmacotherapy. Number two, they need ongoing long-term access to counseling support to make it work and to adhere. And they need coping skills to deal with the changes that we can't make. We can't make them middle class. We can't give them a home, can't do any of those things. Quit lines were the answer for a long time, and we know that we can't get more than single-digit percentages of people who smoke to call them. What are we missing? What should we be doing that we're not doing as a public health strategy?
Yeah, I mean, that's part of the huge question, right? I mean, like, I'm curious in hearing Dr. Levinson's question, do people in the room, does something like pop into your mind of, oh, if we could do? Because, I tend to think, because my questions often come from, if I'm seeing someone one-on-one, what can we do? And that's where, can we connect them to resources, that sort of thing is a little bit different. Now, I know some people from the healthcare systems could say, even from the hospital level or from the healthcare level, we could do more in terms of still doing a better job identifying individuals and then connecting them. And I know some centers have really advanced their navigator or their community health worker programs. And I think that's a huge potential step, because if your navigator can help not just connect you to like the one provider who is going to answer the specific question that you have been called in for, but could actually start to connect you to a host of things that might be helpful. But really, I think I teach a course on designing public health interventions, and a lot of the questions, like the examples that I've sent so far, okay, those are designing interventions. But a lot of students are just saying, okay, but really from the policy, really you need the big moves from a policy level And that's where I don't really know what's, not only what would be the best policies, but even for that, what is the research that you could do that would support the argument for the best policies? And how do you communicate that effectively? So right now, I'm also thinking about, how does communications fit in with what we are doing? And how we can actually get that message to the people who could make the differences, or the type of messaging that might influence who you elect to make the policies that could make differences. But that's where I would definitely rely on, colleagues who are so much stronger in policy and thinking about things kind of from that other end of the socioecological perspective. But if you have ideas, that's really great. What else?
Yeah, I have, I love seeing the data on intermittent and non-daily smokers, because that is such an understudied group. I have just a couple of questions about working with that population. One is, just gonna throw them both at you. One is, do you change your counseling at all for people who are intermittent or non-daily as heavy smokers? And two is, what was it like engaging people in treatment? Like because it has been a group that, providers may not be as, proactive or pushy about engaging as others. And so how have people been interested in engaging in treatment when they're non-daily or intermittent?
Well, so from a research study, you can try to recruit individuals more broadly. I would argue that, I don't have good data on this, but if I was going to guess what the data would look like, I would guess that if you actually dug into electronic medical records, or even did some better way of figuring out who's being assessed, I'm guessing that we're missing the majority of non-daily smokers when we're doing our, at least systems level assessments. Because if I am a non-daily smoker, I don't think of myself as a smoker. And so unless you're asking me, have I used, even a puff, if I used any tobacco, even a puff, even whatever, in the last 30 days, that's the only place that you're going to potentially catch me and have me, say, oh, we're even going to have a conversation. That's what I'm guessing. Would you agree?
Yeah, I think you're right.
Missing?
I think the way we ask is probably missing a lot of people. And so that's why I'm wondering, like, they may not see themselves as treatment eligible.
Yeah.
Because we are not treating them like treatment eligible in the system.
Right.
Yeah.
So, I think that's a big issue, is that and I get it, in our assessments, and especially in like the electronic medical records, for like trying to figure out the minimal number of items that you need to ask people, so you're not driving your patients insane by giving them the same questionnaires with 5 million questions. But like, how do you actually capture some of those? And I definitely think that asking with the assumption, if I approach everybody with the assumption that you've used some form of tobacco, as opposed to framing it in a way as if like maybe you're one of those unusual people who just, if I'm making the assumption like, okay, you've used some tobacco in the last 30 days, and how much are you using, that maybe I'm more likely to catch you. But then in terms of your other question, which is just what do you do clinically? Like, what if you have the luxury of actually having a conversation? If I had the luxury of actually having a conversation with someone, I would want to do a pretty good just tobacco use history, how much are you using on what days and when, and that sort of thing. And how long, and what's it been like, and when have you tried to quit, and how was all those kinds of questions. I think you are to some degree individualizing treatment for people once you get that far. If it's simply, have you used any form of tobacco? And then let's use an opt-out approach where you're using any tobacco, let's get you on medication so that you can stop using tobacco, and then get into the what's worked, what hasn't worked, and why. But you have an opportunity to talk to people about health risks related to tobacco use for anybody, for even those really low level individuals, and then anyone on the other end of the spectrum, which is like cancer patients. Because I think historically the whole thing was, One, people who are low-level smokers don't need intervention because they're not really addicted and it's not really that big of a deal. But it still is harm, and so it really would be unethical to not intervene. And then on the other end of the spectrum is, oh, if you have a new diagnosis of cancer, you're too stressed out with other things, so it would be wrong of me to spend time intervening with you because you need to focus your efforts elsewhere. No, now we have really strong data that says that we really need to intervene, so that's the challenge. And then as we were talking last night, you know, if you have a pregnant individual and you're asking about tobacco use, are you asking about any kind of substance use in a way that is open, non-judgmental, normalizes it so that it's like, of course, people use substances. Let's identify what they are. Now let's talk about risk and intervention and help and that sort of thing.
And also, are you in a state that has a punitive system for them disclosing that?
Yes, that is true. So, I mean, ultimately, I think everybody's in the same game in terms of like, we want to help people have smoke-free living. Here's a couple additional resources. I really like this particular Addressing Tobacco Use in Black Communities by the American Lung Association. American Lung Association is a great place to still continue to go to get resources. American Cancer Society is still a good place to go to get resources. So some things to just keep in mind. And my email to follow up with anybody. If there's anybody who, you know, has had a chance to ask a question and you want to follow up, please feel free to email me. If you want to chat, we can set up a time. Anything like that. Thanks so much.
You.